morning, everyone. Uh, on behalf of Ceylon College of Physicians, I would like to welcome you all who are physically here and participating virtually for this specialty update on rehabilitation medicine. This is the first ever specialty update organized by Ceylon College of Physicians. For obvious reasons, I'm being the president 2023. And today to co-chair with me, I have my good friend, Dr. Gunendrika Kasturatna. Both of are actually now ex-presidents. We had our AGMs both during last 1 week, but so as the presidents of 2023, we'll be, two of us will be chairing today with the permission of the new presidents. So today we have 3 speakers. We have a guest speaker from UK who will be joined live online, Dr. Ilmas Kara, a consultant in physical and rehabilitation medicine from UK, and 2 of our new kids on the block, Dr. Chamara Jayatunga and Dr. Kallahari Sewandi, who has gone through our very new program, post-MD rehabilitation medicine program, and finished their foreign training, has just returned. So they will be the future of rehabilitation in Sri Lanka. And we are very happy to hand it over to them. So to start with the first lecture, I would like Dr. Gunendrika to introduce the lecturer, Chamar.
Dr. Chamara Jayatunga. He obtained the MD in medicine in the year 2019. Worked as a specialty doctor in neurorehabilitation from December to November 2023 at Royal Berkshire NHS Foundation Trust. Also completed a diploma in musculoskeletal medicine from Faculty of Sports and Exercise Medicine UK, and he's a diplomat member of the Faculty of Sports and Exercise Medicine United Kingdom since October 2023. He'll be conducting a case-based discussion on rehabilitation of a critically ill patient. Over to you, Chamara.
Hello, everyone. And thank you, sir and madam, for the kind introduction. And it's good to be back on this stage after 4 years since I had my last lecture. Okay, so the topic for today's lecture is rehabilitation of a critically ill patient, a case-based discussion. And the objective is to give an overview of the approach to a critically ill patient from rehabilitation point of view, and also to highlight few concepts of rehabilitation. So this is a patient that I saw recently when I was in the UK, Mr. A.L., a 54-year-old male who was previously fit and well. He's an avid cyclist who cycles up to 10 to 15 kilometers daily, a software engineer, and he lives with his partner, and he does not have any kids. So he presented to A&E with acute onset progressive lower limb weakness, and the diagnosis was established as Guillain-Barré syndrome. And then the paralysis worsened, cranial nerves were also involved, and he developed respiratory weakness, so he was transferred to ICU, and he was intubated and ventilated. Then the patient was referred to the rehab team after about 2 weeks in the ICU when he was medically stable. But when I saw him, patient was still on the ventilator, and neurology team has reviewed him and treatment completed. So how to approach this patient from a rehabilitation point of view? Before that, I will quickly go through a couple of definitions just to recap for those who are unfamiliar with the definition. So this is the WHO definition, which is proposed in 2021, which is a set of interventions designed to optimize functioning. That's the key word, and reduce disability in individuals with interaction with the environment. The British Society of Physical and Rehabilitation Medicine in 2010 kind of expanded it further, and they have included a couple of other important domains. For example, participation in society and quality of living. Right, so what is the rehabilitation approach to any complex patient? I would like to kind of divide it into 5 steps. First one would be to identify the problems, and then an assessment, goal planning, outcome measures, and treatment, or interventions rather. Right, so we'll go through these 5 steps with our patient who is with severe GBS, who's on ICU. Right, so step 1, identify the problems. For that, we need a model. And the widely accepted model is the WHO ICF model, which is the International Classification of Functioning. The rehab trainees might be aware of this, but for the general audience, I'll quickly describe. So we have 3 main domains: the body functions and structures, activities and participation. These 3 comprise of disability. That means impaired body functions and structures, activity limitation, and participation restriction. So these 3 are the 3 main domains of disability, but that is perceived disability depends on environmental factors and personal factors. Right, so when I saw this patient, I tried to apply that concept to his condition. So what are the affected body structures and functions? Mind you, this is for the ICU phase. So he was quadriparetic. He has severe dysphagia, or pharyngeal dysphagia. He was on NG tube. He had siluria, which is drooling, respiratory insufficiency. He was ventilated, bladder and bowel incontinence. Mood and psychological, we can't assess, but most likely he would have had. And then pain. And then potential complications: reduced joint range of motion, contracture formation, nutritional impairment. Mind you, these critically ill patients are catabolic. And on top of that, he has a severe peripheral neuropathy, the GBS, and of course, the cognitive impairment. Then impaired activities, as we can assume, he's dependent in all the ADLs at the moment. Participation restriction, literally everything. Now, this is an important aspect in rehab planning. We have to always get a detailed history. For example, when the patient is in ICU, I have to rely on the ICU team or the A&E team who has got these sort of information. And then the next step would be to, because the patient will be with the rehab team for a considerable time, so we can always get in touch and then get these additional information, very important. For example, what sort of personality? What are his general coping strategies? What's the social background, education? And what are the ideas of the family and the next of kin? And also the motivation shown by the patient in previous distressing events. Very important to predict the course of rehab. And of course, the environment. Barriers, financial and social. Right. Then assessment. So we identify the impairments here. We are at this level because the patient is critically ill in ICU. These will be at a later stage. So mainly at the moment we are focusing on the body structure and function level. Right, so assessment. So for muscle weakness, what we do is testing of muscle power, the basic examination, but the patient is, when I saw initially he was paralyzed and ventilated, so we can't test that. Joint range of motion, very important. Usually these can be done by because I'll come to that, the rehab services are delivered by a team. So sometimes the physio team can help you with this and do the full joint range of motion because the patient is positioning definitely would need assistance of another clinician. It's difficult to do by one person practically. And joint range of motion, important, the shoulders and neck if possible, because they can get flexion contractures of their cervical spine if like this, or it could be any direction. So better to get a cervical range of motion assessment if the spine is stable. And then hips, knees, and ankles. And we can use a goniometer. It is like a ruler that we use for documenting the baseline range of motion. Siluria and secretion burden, very important for patients who are ventilated. And pain, difficult to assess at this stage. Patient might not be interacting, but you can get inputs from the ICU nurses and also from the physio team for any visual analog sort of assessments of pain. Nutritional scoring, there are numerous scoring systems, and usually the ICU team will look into this. And cognitive impairments. There are multiple studies done showing that the patients who are ventilated will have cognitive impairments. Screening can be done by like a MOCA, the Montreal Cognitive Assessment, or even an Edinburgh Cognitive Examination. But mind you, this is very basic assessment, just to establish that the patient would need detailed assessments, which are usually done by the OT team or, if available, a neuropsychologist. These are very expensive, and we need to purchase from the developers. So what we use there is called R-band. But for initial assessments, a MOCA is enough, which is not copyrighted. But when the patient is ventilated, again, we might have to wait before doing these. Right, this is the Siluria scoring system, which is a good, easy to do one. So we check the severity as well as the frequency. The higher the score, the more disabled or more severe the problem is. Right, step 3 and 4, goal planning and outcome measures. We all know this mnemonic for goals, SMART goals. So I try to put several goals for our patients. So what happens is actually, initially when the referral comes, a doctor would go and see the patient in the ICU, then get information about how the medical things and how stable the patient is. And then we speak to the ICU team. So they have their own physio, speech therapist. And then we discuss my examination findings with theirs. And then the rehab team will have a meeting. And then we go through the patient again. And then we try to set the goals. So I try to put SMART goals for this patient. And they will have all the domains of functioning, from physical to psychological to social. But here, when the patient is in ICU, I try to put mainly the physical ones. So one of the key goals when a patient is critically ill is to preserve passive joint range of motion in upper limbs and lower limbs. Always we try to put a time frame, so 3 to 4 weeks, and specific to prevent contractures. So why is this important? Anybody has any idea why this is important? Any volunteers? Let me explain. Because at the moment, our patient has severe Guillain-Barré and on ICU. And if we don't maintain the joint range of motion in the functional position of the anatomic position when the patient recovers, because the prognosis of Guillain-Barré with the treatment, they will, after a period of plateauing, they will start improving. So by that time, when the neuronal recovery occurs, if there are joint problems, which the patient does not have at the moment, that will be additional burden, and it will take time to improve with physio alone. Sometimes we might have to do surgery. So always better to prevent it. So as the rehab team, when we go to see a referral in ICU, perhaps we can have a chat with the ICU team. And in the intervention component, I will show what are the things that we can do. So that's the important goal. And then to preserve muscle mass as much as possible. Definitely they will have some degree of muscle loss. It could be the disease itself. It's a severe peripheral neuropathy, catabolic, probably secondary sepsis. Sometimes they treat with medicines with muscle weakness. But preserving it is a very important goal. And then to help the ICU team to wean the patient from ventilation as soon as possible. I'll tell you how we can help with that. And then patient to be able to sit in a tilt and space wheelchair for 30 to 60 minutes by 3 to 4 weeks, because it's difficult to achieve this. I'll explain why. And then, of course, to prevent pressure ulcers and ensure that next of kin and immediate family members are aware about the next steps. Because these days they have access to the social media and they have seen these success stories online. So they are very keen to see what are the steps available for their patients. So better to initiate the discussion. Parallelly, Other secondary rehab goals, screening for cognitive impairments if possible, pain relief. Usually the ICU team and the pain teams, they are already started it by the time we see, but there are some physical things that we can do as well. And also assessment for psychological and mood impairment, depending on the patient's participation. Right, step 5, rehab interventions. Before that, just to remind that it is delivered by a team of professionals, and everybody is each professional is an independent clinician, but we work in an interdisciplinary manner, and the specialist is the team leader, but there's no hierarchy. Depending on the patient's impairments, a professional might take a leading role. But for patients who are in ICU with multiple comorbidities, perhaps the medics will have to do more initially. Do I need to go through the general roles of these professionals, or can I? Yeah, I'll skip that. Yeah, right. So here I try to put the rehab interventions that we could do for critically ill patient while in ICU. So I try to put the goal and then what we can do. So the first goal, to preserve a passive joint range of motion. So correct positioning is very important. So generally accepted time is to turn the patient every 2 hours. Generally the ICU team is well aware, and it needs a lot of manpower to do this. So it's very important. And then we can put the resting forearm and hand orthosis. We call it splints. And they have to be on and off every 2 hours. Otherwise, the patient might develop pressure ulcers in the skin. And then resting ankle orthosis, which is here. Again, the same principle. Every 2 hours, we need to change it. And then daily passive, if the patient can do active range of motion exercises to all affected limbs. To preserve muscle mass as much as possible, what we can do as the rehab team. We can go through the medication list and just see whether the medication list is optimized, whether there's any steroid. We can have a chat with the treating clinician and express our concern that losing muscle will prolong the recovery. So whether there's any possibility of switching to steroid-sparing agent and optimize the nutrition and the medical management. Sepsis is well controlled. Usually these are done by the ICU team, but we can give our opinion about the medication changes. And then this is something we can do actively as rehab team to help to wean the patient from ventilator. One of the main reasons is the siluria or the secretion burden. It could be, we use the term drooling when it is evident, when the patient is, we see the saliva dipping, but sometimes it can be posterior accumulation where we can't see when the patient is supine. We need MDT inputs, speech therapy inputs, and sometimes they do flexible endoscopy of swallowing just to see how much saliva is pooled. And if it is a problem for weaning, yes, we can start the oral medications. These are antimuscarinics, all have cognitive impairments, but we need to balance the benefits, hyoscine, glycopyrronium, and atropine drops. But then now there's evidence that arranging salivary gland botulinum toxin injections has a clear indication, and it generally gives very good results. And so this is one of the key things that we do when the patient is in ICU, ventilator. We tell the ICU physician, let us know if they think the patient cannot be weaned purely because of the secretion burden. Then yes, we can go and treat it. We can do it at the bedside with ultrasound. It's an easy procedure. Right, it's an important goal, to mobilize. So there's multiple research evidence that early mobilization improves outcomes, but nobody's sure what do you mean by early mobilization. Is it bedside physio, or is it mobilizing to a chair? But general principle is it always have a chat with the ICU physicians, and if the patient is medically stable, we can start with gentle movements as tolerated, and then take it from there. So, for example, for our patient who is paralyzed, ventilated, to get to a wheelchair, to sit 30 to 60 minutes, it's a combination of smaller goals. For example, he has to be medically stable, not on any inotropes or anything. Pain has to be well controlled. And mind you, these patients have so many causes of pain. They would not complain of pain, but the physio will come and tell you, patient is not engaging well. So then we need to think, or one of the therapists might say, patient is not engaging. He's in distress when you try to mobilize. Then one of the commonest causes is pain. And it has, as I mentioned, so many differentials. And one of the differential is heterotropic ossification. That is formation of bone in the soft tissues. Unless somebody looked into that actively, it will be missed. So we need to do x-rays. If patient is a kind of prolonged course of ICU stay, and the physios are telling patient is in pain and passive range is restricted, always do radiograph to see ossification of soft tissues and muscles, very common. And then postural balance has to be optimized. Can be muscle weakness in the trunk axial muscles, so the patient is not able to tolerate the wheelchair. And there can be head drop as well because of the sternocleidomastoid and neck muscle weakness. So these has to be sorted. And then postural hypotension, very common. And then safe transferring has to be established. We need trained staff, equipment. So this is a ceiling hoist, which is needed to shift a ventilated patient to the wheelchair. It needs 2 physios and a nurse probably, so 3 people. And it's very difficult to do this every 2 hours. So usually in practice, what happens is patient is once transferred to the chair, they will remain for 2 hours and then back to the bed. And then we need a good tilt-in space wheelchair with good cushion and support. We need head control because this patient is weak. It's lower motor and cranial nerve, so he had a head drop. And we need trunk support. We need pelvic support. So generally, tilt means the patient can be tilted backwards. It's not reclining. So the patient's hips are like this. Right? So the back is 90, hips are 90, knees are 90, ankles are 90. So we can get the anatomic best functional position. That's the normal position. Everything at 90 degrees. That's the easy way to remember. Because if you just have a reclining wheelchair, you can't get the hip at 90. Hips will be straight and the spine is backwards. So you get extra pressure on the sacral region. So this will shift the pressure from sacrum to back. So this is called tilt and space wheelchair. And then the goal to prevent pressure ulcers. Again, proper positioning, special mattresses with air fluid interfaces, and changing position, as we all know. Right, educating the next of kin is also very important to avoid acquiring wrong information. The best way to do is to have a team discussion and then approach the patient together with the MDT and the ICU physician. Otherwise, patients might get a wrong impression, especially about the prognosis. They will be asking, the ICU team will ask the neuro rehab team, what about the prognosis? Do you think this patient is rehabable, or shall we send the patient to the palliation pathway? So that needs, so then the answer would be we need serial assessments, we need an EEG, we need repeated at least 4 to 5 weeks of weekly assessments. Then only we can get the trajectory and a bit of natural history and literature review. So it's a very tricky question to answer, but they will ask you. Right. I didn't mention one of the common rehab interventions that we do while the patient is in ICU, which is the spasticity management. Spasticity means increased tone, which is velocity dependent, and it has its own set of problems with pain, contracture formation. So and they have multiple comorbidities, so medication might not be the answer. We can try a bit of baclofen, but generally we go for, if it's a focal problem, we go for botulinum toxin injections, right? For example, for clearly identified goals with the physios. For example, if the patient can be kind of get to the standing position, but he has a foot drop, so the patient can't get the heel on the floor, and that the patient might trip. So we can inject the, if it is spasticity, it could be a contracture, it could be soft tissue. Then now if this patient gets a foot drop, it's not spasticity because it's a lower motor disease. The referral would come, patient has foot drop, can you consider a Botox? But no, it's a lower motor. So it's soft tissue contracture, it's physio and maybe surgery. But let's say it's a stroke, head injury, you do the CT, you have corresponding lesions in the tracts, yes. Then and of course you examine as well. There's clonus, you go for Botox. So that is something that we can help the ICU to prevent contractures, prevent pressure ulcers, reduce pain, to get to the wheelchair, and for more interactions as well. Because when the patient is lying on the ICU bed, just looking at the ceiling, the first step of cognitive rehab is to get more interactive with the environment. So get into the wheelchair, he can interact with the family. So that's important because sometimes they get severe flexion contractures or spasticity in the large muscles in the legs, so they can't sit on the wheelchair. Like for example, quadriceps. So we inject if it's a problem. Right, so the course of hospital admission. So patient actually started improving neurologically, which is the normal, generally accepted course in GBS. And then he was weaned off, tracheostomy removed, and did not require salivary gland. And then he was stepped down to respiratory ward. And then what's the next step in the path to recovery, which is inpatient, goal-directed rehab. And what's the next step in rehab point of view? Again, back to my 5 steps. We'll re-identify current problems, assessment, goal planning, outcome measures, and treatment. Now things have changed. How much time do I have? Like 10 minutes? 5 minutes. Right. I'll quickly go through the affected body structures and functions now. So now, predominantly distal upper limb weakness because it's small muscle weakness, the residual problems of severe GBS, and of course, proximal lower limb weakness. And each will have their differential diagnosis. So as medics, that's where our expertise comes. We need to think which one is the problem. So for this patient, for proximal lower limb weakness, it could be nutrition, it could be catabolic, right? So a lot of causes are there. It could be critical illness, myoneuropathy in addition to original GBS, and then small muscle weakness leading to claw hand. So, and then bilateral reduced active shoulder joint. Again, the patient, when you ask to do, power is back to grade 3. So when you ask, can you raise your arm? He would do up to this. But this is very non-functional. He can't do anything. But when you check the power, 3. Then we need to see what's the problem. Is it joint? Is it soft tissue? It is spasticity, again, out here. Is it the pain? Or is it the combination of everything? So do bedside clinical examination and an X-ray is enough. So the main differential diagnosis was, or the other one is whether it's muscle wasting because he was in ICU for weeks. So on the right side, it was adhesive capsulitis was my main differential. So we went ahead with physio for a few weeks and then steroids. On the left side, it's wasting, hardly any muscle mass. So because the right side injection worked, he asked for an injection for the left side. But then we explained, no, it's muscle wasting. It will not help. So we continued with physio, and it can be given in the clinic if it remains a problem. And then mood is very important. He was very anxious, and he was not engaging in therapy. So we need to address that, and deconditioning. Impaired activity is the same, but just to mention, using mobile phone is a big problem nowadays. Signing, driving. Yeah, these are the same. So just to see how we set goals in rehab phase, just very briefly. So initially, we were getting him to the wheelchair by 4 weeks, but now we are thinking of transferring independently with use of an aid, which is a frame from bed to chair, again by 6 weeks. And to able to walk indoors, because one of the concepts of goal setting is to be realistic. I mean, patient would say, can I walk? He's a cyclist, but we are becoming a bit realistic. We are saying, maybe not at the moment. So we are going for walk indoors on flat surfaces, that is like inside the ward, with a walking aid, without supervision by 6 weeks. Because of those impairments, it will take time. And then basic ADL independence by 6 to 8 weeks, and then full swallowing by 4 weeks. He was on a modified diet when he came. And sometimes you might not, it's difficult to appreciate when during the lunchtime, when the patients are having dysphagia, but cognitively better, when they get the smell of food. It's very distressing, and it's being served to all the other patients. And I realized it when you talk to the patient. It's one of the, so we always put that as a goal as well, dysphagia, and engage in leisure. Right, so what happened? So we kept him for 12 weeks for inpatient, and then we had a goal planning and a goal review after 6 weeks, and then we had a family meeting after 8 weeks, and then we established he can be discharged after 12 weeks in the ward. That is, after about another 12 weeks, he was in the ICU. And he can go home, but he was able to transfer independently, but walk indoors with only elbow crutch. And still he needs the wheelchair, which is self-propelling for long distances, which is good because he lives only with the partner and she was working. So patient can, self-propelling means he can, because it's all, accessibility is there. Sometimes he can also go to the nearby shops as well. And normal diet and fluids, bladder and bowel continent. But he had residual problems in the hand. We couldn't get it fully. He had severe neuronal loss, and the left shoulder the muscles were very atrophic. We tried all the interventions, including electrical stimulation. It didn't fully improve. So there were residual, which is part of the GBS natural history. So you educate the patient and try to help to achieve his task. So he could use the mobile phone and the laptop, but it was very slow. He was IT guy, so for him, we are not there yet when he was discharged about a month ago. So next step, discharge home with community-based rehab, which our current rehab service is lacking in Sri Lanka, and then arrange follow-up in 3 months to see how he's doing. So that brings the end to the case, and these are my take-home messages. So WHO ICF model is very useful when you see a complex patient. And then, of course, it's always SMART goals. We can't use SMART concepts to all the goals, but we try to put the time frame, which is important. And then we need MDT, of course. And then maintaining good rapport and coordination and communication channel with ICU can improve functional outcomes in critically ill patients. There's research evidence for that as well. So I would like to acknowledge all the consultants and all clinicians, admin staff involved in maintaining and initiating rehab services in Sri Lanka, and of course to the ICU and neuro rehab units at Royal Berkshire Hospital, and to all my teachers and my patients. These are my references, and thank you. Any questions?
Thank you, Chamara. I think we'll take up few questions in end of the session because Dr. Ilminskara is online, so I think we have to give a chance and then release to get back to her work. It's very early morning in UK. And to introduce Dr. Ilminskara, I would like to invite Dr. Gunendrika Kasturatna, the president, immediate past president of the College of Rheumatology and Rehabilitation in Sri Lanka.
Dr. is a consultant in physical and rehabilitation medicine and is currently the educational committee chair of the British Society of Physical Rehabilitation Medicine. Her talk for the day will be on stroke rehabilitation in the early stages. Dr. Ilminskara, good morning. Do you hear
Hello,
us?
good morning.
Good morning.
Yes, can you hear me all right? Good.
We can.
Good.
Very well heard.
Good day to you. I think it's around lunchtime in Sri Lanka.
Yes, of course. But we all are very, eager to listen to your talk. And thank you very much for accepting our invitation. Over to you.
Yes, can you hear me all right? Good.
We can. Very well heard.
Good day to you. I think it's around lunchtime in Sri Lanka.
Yes, of course. But we all are very, eager to listen to your talk. And thank you very much for accepting our invitation. Over to you.
Thank you very much. Thank you for inviting me today to speak in the Speciality Training Day of Salem College of Physicians. I am a consultant in physical and rehabilitation medicine, and I specialize in neurological rehabilitation. I work in England, in Royal Berkshire, and also in Oxford. Today, I'm going to try to summarize stroke rehab in the early stages. My declaration of interest, I don't have any, apart from it's very early in morning and it's raining here in Oxford, so bear with me this morning. So what I'm going to try to do today is to give you a very brief introduction, then we'll have an overview of stroke rehab, including goals, MDT approach, and personalized plans. And we're going to touch base on medical issues, motor recovery, spasticity, pain, swallow of speech, cognition, mood, sleep behavior, and all the aspects that we go through in rehab process. Very briefly, advancements in stroke rehab, and we'll talk about challenges. And I'll touch base on the structure of the stroke rehab in the UK, and we're going to finish with the summary and questions if you have any. And just to check before I start, I know that it's a hybrid meeting. Can you hear me all right? And can you see my slides?
Yes, we can. We can.
Thank you very much. So I'm not going to prolong the facts so much, because as rehab physicians, we know that we deal with more NFACs and mostly thrombotic events, but sometimes embolic and lacunar, and hemorrhagic less, and they are more intraparenchymal and subarachnoid. Epidemiology changes all across the world, but what doesn't change is it's a leading cause of mortality and morbidity across the globe. So whereas it's England, Sri Lanka, America, or rest of the Europe, it is a leading cause. And with rehab, we can now promote recovery as well as function and quality of life improvement. If we have an overview, we have to touch base on goal setting and the importance of having a team on board, a multi and interdisciplinary approach, and tailoring the rehab plans for our patients. Goal setting, Chan, before me touch base on SMART goals. We may not achieve that all the time, but that's the aim, to establish specific, measurable, achievable, relevant and timely goals, so we can know where and how we are going, so we can assess our outcomes accordingly. So that's a generic principle to put in our pockets. We are fortunate to have full MDT across the UK usually. It's usually led by a rehab medicine physician like myself, and we work alongside our rehabilitation nurses, therapists, physio and occupational therapists, speech and language therapists, neuropsychologists, dietitians, orthotics and social workers. And of course, we sometimes have care coordinators, an admin team, and some specialist nurses and therapy assistants in the team, but this is the core team we must have in the stroke rehab MDT. Talked about tailoring rehab plans. Of course, the type and the location of the stroke will impact. So if we're dealing with a more frontal injury, we may be dealing with cognitive aspects like impulsivity, for example, or if we're dealing with a thalamic stroke, pain and sensory issues could be more problematic. Obviously, we're going to take into account of the age, gender, and premorbid and present function of our patient and how they are presenting clinically in this moment. What we need to establish is a needs-based rehab, so that's individual per patient, and of course we discuss with patient and the family, and we take into account in their preferences when formulating a rehab plan. Neuroplasticity, so it's there for a few decades now, maybe 30 years, and that was a game changer in the field of rehab for us, because before we didn't know that we could promote recovery, but with discovery of neuroplasticity we know that it's possible up the first 2 years, but it's highest in the early phases, and it's difficult to define early. So what is early? But let's say for this talk we're talking about the first 6 months, again, which then the neuroplasticity is in its high peak during that period. We're going to have a quick overview of all the issues I listed here, so I'll try to go one by one and summarize the message possible. Let's look at the medical issues. Obviously, there is acute management of stroke, which I'm not going to talk about. This is normally dealt with neurologists or stroke physicians. What's important for us as rehab medics is to identify causes if possible. If not done in the acute setting, then that's us investigating the causes. We may not identify a cause each time, But it is important for secondary prevention. For example, if we determine atrial fibrillation, then we'll look into anticoagulation with DOACs, for example, or we must look into secondary prevention. And cardiovascular risk factors is imperative to look into and modify when possible. Obviously, age is the single most significant non-modifiable risk factor. We can't really do anything about it, but there are modifiable risk factors like blood pressure management is the most significant and important. A modifiable cardiovascular risk factor, and with the release of the new NICE stroke rehab guidance and update of the NICE stroke management guidance, we now can aim for lower blood pressure thresholds. Obviously, with the bleeds, we aim for a tighter blood pressure control, and statins for cholesterol, for example, and lifestyle modifications. It's more for subacute and chronic phase. If we look at the medical issues on the rehab ward, in the early phases, probably one of the most significant ones would be an hemorrhagic transformation or a recurrent bleeding. That's obviously a urgent attention to your patient, doing your ABCD approach and doing an urgent CT scan. And then liaising with neurosurgeons for conservative versus surgical management. And seizures can be an issue in the early stages. They're provoked and non-provoked seizures. Provoked are usually with an underlying cause like an infection, electrolyte imbalance, etc. Within the first 72 hours of seizures, we don't accept that as epilepsy, and we may do some anti-epileptic loading, but in the long run, we don't keep our patients on anti-epileptics, but this can be an early stage issue. Of course, pulmonary emboli or VT can be a significant factor because of the predisposing factor to coagulation and also reduced mobility usually. That's why we must assess and screen our patients for VT prophylaxis and prescribe accordingly. We know that within the first 28 days, we do intermittent compression, and then after that, we can do low molecular weight heparin. And also test stockings, depending on our assessments. We also on rehab wards often deal with sepsis, delirium, aspiration pneumonia, and falls, and many other medical issues like electrolyte imbalance, metabolic bone disorders, for example, for electrolytes, hyponatremia, and hypercalcemia can be issues. So these are the medical issues. Let's look at the rehab issues and start with motor recovery. In my experience with rehab in the last 15 years, in neuro rehab in the last 15 years, there are a few significant factors that's very important to the patients, and one of them is motor recovery. Can I use my hand again? Can I walk again? In stroke rehab, I always emphasize the Bronstorm stages of recovery, motor recovery. As you know, we divide that into three, with as upper limb, hand, and lower limb, and that consists of stages, 6 stages. First would be is flaccid stage, and then stage 2, there is increased muscle tone. Stage 3, further increased muscle tone, and then 4, then the muscle tone decreases, then we can see complex voluntary movements, and 6 would be isolated movements. Usually, I'm not sure how in Sri Lanka, but across Europe and England as well, the physiotherapists also and occupational therapists also usually follow the Bronstorm approach of motor recovery in their therapies. Of course, in motor recovery, we're going to talk about dominant versus non-dominant side. Typically, when we are talking about stroke and stroke rehab, we're talking about hemiplegia. And of course, someone who his dominant side is affected would not present same as the non-dominant side, and we're going to take into account, and we may need to often train the other side, and we'll talk about that. The newly released NICE Stroke Rehab Guidance emphasizes on early mobilization as early as 24 hours, which actually that caused a bit of a controversial conversations across England, but that's the current recommendation. Of course, if that's appropriate, we're going to go for early mobilization and gait retraining again when appropriate. We'll start with sitting balance, standing balance, and then we'll talk about stepping and gait. And motor recovery therapy would include strength and fitness training, stretching if appropriate, and splinting, orthosis, and knee stimulation, especially for upper limb and lower limb. And constraint-induced movement therapy, repetitive task training, and mirror therapy. And the latter three, we know that they are evidence-based to promote neuroplasticity. So we often implement those approaches in our motor recovery program. There's this million-dollar question about, do we compensate or train? What I mean with that, if I am dealing with a patient who has left-sided weakness, do I train the left side? Do I try to improve the functioning, the presentation, the tone in the left side? Or do I compensate the weakness in the left and train the right side? Or do I do both? So I think in the early stages, the research, usually based on the functional MRI studies, show that try to avoid compensation in early phases and try your training in the early phases. That would promote neuroplasticity more. However, we're going to talk later that you don't always want to underline what's lacking in your patient. They also need to function. They need to eat. They need to wash their faces. They need to brush their teeth. And if they have a non-functional side, let's say left side, and you are trying to train that left side continuously, then what will you do? Are you going to add additional help for that patient for basic life tasks? That's a bit of a delicate balance here. You're going to do both, but you'll prioritize training in the early phases when the neuroplasticity is in its peak. That's the evidence. So that's what we're trying to achieve. Again, spasticity, before me, I just logged in the midway of Cham's talk, but he touched base, I understand that. But we know that post-stroke, usually the high peak is around first 4 weeks. And we see in 1/3 of stroke survivors, even after 12 months, they do present with a form of increased muscle tone and could be disabling or severe. And this is the typical patterns of upper limb spasticity following a stroke. And one, so is the one that we would most see in our clinical presentation. We're going to see a hand and arm very close to the trunk, and with a rotation, adduction of shoulder, and all the way flexion and supination. So this is the most common pattern, and we can see the others. So what do we do about spasticity? Do we treat or not treat? Because I did talk about the Bronstorm stages, and it does emphasize that the natural recovery, motor recovery, includes increasing of spasticity and then decreasing. So what do I do about it in the early phases? There are evidence that shows that you can even utilize toxin if you want, but obviously you don't stick around your needle and try to inject everyone. We do a thorough assessment of the spasticity. It's not always bad. It can be useful and it can be good. For example, we are talking about gait retraining, and we don't want to interfere with knee extensor spasticity because that's useful for standing. and transfers. But for example, if we're dealing with a hand function and very flexed hand, and then in our assessment, if we determine that the flexed muscle tone is the reason of not moving further in the branch-term stages of recovery. For example, you can't overcome the flexion because of the muscle tone to achieve extension, because then if you don't have finger extension, then you can't have isolated moments, then you can consider toxin. So that's the spasticity. Pain. Is it neuropathic or musculoskeletal pain? I'll tell you, it's going to be a bit of both. Of course, with the stroke type and location, we can have an idea of is it more neuropathic or not, but not all the time. And if our patient presents with communication difficulties and cognitive difficulties, it's going to be very difficult to assess the pain. We're going to rely on facial expressions or estimation, really. We always start with physical measures, especially with BMSK pain. We explore posture, anatomy, and psychosocial factors, any yellow flags. But we do want to do medical management when appropriate. We don't want a chronic established pain in our stroke rehab patients. So we'll utilize GABAergics, amitriptyline, duloxetine, and obviously good old paracetamol. And we can also consider advanced options. Hemiplegic shoulder pain as a specific entity for stroke rehab. We deal with hemiplegic shoulder all the time, and we know that that's usually peaks around post-stroke week 4 and 6, and not very initially. And the shoulder itself is a very unique joint that's held together with the muscle tone and the muscle power. So when you lose that after a stroke, then we're going to have a combination of MSK and neurological factors contributing in this complex phenomenon of hemiplegic shoulder pain. The first goal is to prevent positioning, posture, support. And there is a risk of adhesive capsulitis, which would then lead to poor quality of life, poor therapy engagement, and overall very discomforting for our patients. And management, we would do taping, electrical stimulation, and also we would consider steroid injections and nerve blocks as appropriate. But that's again a multidisciplinary approach, and you always start with physical measures. Swallow. So we could be dealing with dysphagia or apraxia of swallow, and the guidance says all patients after stroke, that's a bit of an ambitious, but they should have a swallow assessment following 72 hours of a stroke. But that's the aim. And the first line is obviously the bedside assessment by the speech and language therapists. If you want to do radiological assessment, you can do FES, which is the first line, or radiofluoroscopy. Our patients may be needing enteral feeding in early phases. We see more nasogastric tubes rather than PEG, because PEG is a big decision, but we may see patients in early phases with PEG as well. We must assess nutritional status and hydration, especially with swallowing difficulties. And when they don't have an enteral feeding way, then we may be jeopardizing their hydration and nutrition. Oral intake with dietary modifications is usually the standard approach with swallow impairment. I must emphasize the physical measure, like having an upright posture, maintaining the oral hygiene, and treatment of oral thrush if there is any. Obviously, prevention is integral. If there is sialuria, we need to manage that first with physical measures and botulinum toxin if needed. There's a significant risk of aspiration with swallowing impairment. Again, another $1 million question is that do we do diet modification when there is swallowing impairment, or do we do risk feeding? For example, with our assessments, bedside, FES, radiofluoroscopy, we determine that oral intake is not safe at all for our patients, then we are keeping them kneel by mouth. We're asking them not to eat and drink. And that's the early phase that can be acceptable perhaps, but in the subacute and chronic phase, patients may choose to have oral intake with the risks associated, including aspiration, choking, and death. And that would be a patient choice, but that's a very careful, delicate discussion to have. Speech. Again, with the swallow, the guidance says we have to assess communication difficulties within 72 hours of stroke onset. We could be dealing with aphasia as well as a speech apraxia, and we could be dealing with expressive and or receptive language disorders. We sometimes use global communication methods, meaning utilizing gestures or visual aids, for example. I'm Mediterranean, so I use my gestures a lot. So that's probably, I'm naturally a global communicator, but not in all. This doesn't apply in all cultures. But after stroke, we may utilize global communication. And we will consider aids for subacute long-term phase, again, considering neuroplasticity. I'm going to emphasize on the impact on mood and well-being, especially with the expressive aphasia. That's more significant. You understand, but can't express yourself. This is very, very frustrating. And that has usually a direct impact on mood and well-being of the patients, and we have to be mindful of supporting patients in that aspect. Again, do we go for therapy or do we go for communication aids? What do we do? Again, considering neuroplasticity, we must work on repetitive tasks, sound production, mouth, tongue movements, and speech in context, etc. Therapy approach is integral. Communication aids, especially with the high-tech options, it is recommended to wait a little rather than the early phases to come up with, let's say, you don't want to do eye gaze in the first 3 months. It's very expensive and it takes a long time to adjust for the patients, but we utilize basic communication aids like a basic communication books with pictures, for example, even in the early phases. But then after we determine that this is the baseline communication potential for our patient, then we can utilize more complex aids like text-to-speech, for example. Cognitive impairment. Cognition assessment includes attention, memory, spatial awareness, apraxia, again of speech, goes hand in hand with cognitive impairment and perception. We must do our screening assessments, and we must consider pre-morbid cognitive state as well as education and language and communication. Maybe it's not cognition, maybe it's communication. Then it becomes very challenging to assess, but neuropsychologists are trained to assess cognition, even with communication difficulties. And this could be a limiting factor in rehab. And we must look into contributors before determining that established cognitive impairment. When I say contributors, I mean basic things like vitamin B12 levels, thyroid functions, electrolytes, again, mood, well-being. So we must consider contributors. Mood, behavior, sleep. So I put them all together because they make a triangle and impact each other, usually negatively. When discussing mood, we need to discuss emotional functioning versus mental health. Is this clinical depression? Is the patient reactive to their significant life event? Having a stroke is massive. It's very significant. It's life-changing. You find yourself in hospital surrounded by strangers, and you may be needing help in all aspects of your life, which is different than what was before. Or are you clinically depressed? So we must use outcome measures and scales in our clinical judgment. And of course, get help with psychology. We can utilize medication. Exercise would be our first line and review in 2 weeks. And once we start, we want to continue minimum 6 months to avoid for further relapse. Behavior, again, acute versus subacute phase, we may have different approaches. If you're dealing with intracerebral hemorrhage, I would expect the patient to be agitated, especially in the intensive care unit, then we would medicate that. However, in rehab wards, we try to avoid medication unless there's aggression, and we put force measures in place, and identifying triggers is integral in behavior management in stroke rehab. Sleep disorders, again, external factors and the impact of the stroke in circadian rhythm. And let's face it, hospital is not an ideal place to have a good night's sleep. And our patient can have pain and other contributors. If there is a problem with the circadian rhythm, we may consider melatonin rather than benzodiazepines for management of sleep disorders, but obviously sleep hygiene is the first to look into. Bladder and bowel. Again, in my experience, I think there are two integral aspects guiding to independence and a good quality of life. If the first is motor recovery, the second would be bladder and bowel. But neurogenic bladder, we can be dealing with retention, urgency, and overall incontinence, and infections relating to that. And in early phases, we may find our patient coming from the intensive care or the stroke unit to the rehab ward with the indwelling catheter, which is okay. Then we have to consider, do we trial without catheter or not? So do we TWOC or not TWOC? Again, timing of that can be important. If you have a patient who you need hoist for transfers and have 3 people for manual handling, you're not in a rush to TWOC that patient. However, that's the overall aim, if possible, and we would consider anticholinergics in subacute and chronic phases as appropriate. We don't, as a routine, do urogenic studies as we do in spinal cord injury in stroke rehab, but we may consider in challenging cases to ask help from our urology colleagues for urodynamics. And bowels, again, another limiting factor in daily life, and we may be dealing with incontinence, constipation, or diarrhea. Our integral approach is to establish a bowel regime and utilize laxatives and fiber intake as appropriate. I have to emphasize diarrhea or overflow here, because diarrhea may not be diarrhea. Overflow could be presenting as diarrhea, so your patient is really constipated if that's overflow. So you have to use more laxatives and suppositories if needed. But a bowel regime is integral. Obviously, we can utilize more advanced features like transanal irrigation, etc. But that's more in the chronic phase rather than the early phases. There are many other aspects of stroke rehab, which I'm not going to touch base today because of the time limits. But we do look into staff care and independence as an integral part of the stroke rehab from early and late phases. And we must assess our patients for their vision and hearing. Fatigue can be a limiting factor. Often, and again, tailoring with the intensity of rehab fatigue we must take into account. The new NICE guidance suggests very intensive rehab, like 3 hours of therapy in one day, which, I mean, honest, we don't provide in England as of now, even in regional units. And some of it is resources, perhaps, but some of it is because we don't want to face with fatigue. There is muscular fatigue and also brain injury fatigue we deal with, and it's often very challenging to deal with. Again, sexual dysfunction is more of a long-term problem to deal with, but it is an important part of stroke rehab. Skin integrity, I didn't touch base today, but that's from the early phases. Obviously, we do carefully assess the skin, and we want to prevent pressure sores. And again, wheelchair and seating and adaptive equipment and environmental aid planning is very important part of stroke rehab. Community transition. So we may be looking into transition our patient into community in early phases. Not all of them end up in hospital and not in inpatient rehab units, but some of them do. But community transition, if they're of working age, we must consider return to work, usually with a phased return if they're able, or adaptations in their roles, or return to school if they're going to school, and roles in family and society. Role as a mother, role as a father, as a child, as a friend, as a husband, wife, etc. And return to driving and give up license if they can't, or for a thorough driving assessment for adaptations. For example, we can go for a hand-controlled car, or other adaptations whilst driving. Again, the individual's adaptation and adjustment to their impairments, because when they go home and they go to community, they will be different. And acceptance of those could be challenging and could be often limiting if in our rehab and transition, if we can't overcome the acceptance phase. And we must remember to support the family and the loved ones. A patient has a stroke, but a whole family, it has the impact. Let's talk about stroke rehab in England. I'm not going to talk about the whole UK because Northern Ireland, Scotland and Wales have slightly different arrangements, but in England we have a good stroke unit. So ours is Royal Berkshire Hospital, and we've got stroke and neuro rehab units. In our region, our level 1 regional units are Oxford and London, and we're very fortunate to have 2 units in Berkshire, so level 2 and level 3. They're both located in the same hospital. One is upstairs and one is downstairs, but in the same building. Very, very lucky. And we also have fortunate to have a full MDT in community rehab. There's also early supported discharge, meaning that when patients are assessed not needing an inpatient rehab admission, we can also discharge them home to community with therapy input in community. That's called early supported discharge. Let's have a close look up in the units that I work in. So our regional units are Oxford and London. So we're here. So 1, 2 units, Newbury Hospital, and Reading is our acute hospital. So usually patients, so the emergency is in Reading, so patient would be presented here, and our acute stroke unit is in Royal Berkshire in Reading, and we kind of cover an area like this, if you can follow. It's Berkshire. Advancements, I don't have time to touch base, but obviously we're all following with excitement developments in artificial intelligence and virtual reality. I'm personally interested in artificial intelligence and interpretation of MRIs. I'm following those to see if we could put that in practice. And telerehabilitation is huge now. That's probably one of the few good things came out of the pandemic, that the rise of telemedicine, again with telerehab, and now in England the new setup of virtual wards. So patients stay in community, but we do liaise with them through video and phone conversations, and need research trends in stroke rehab, usually around motor recovery and neuroplasticity. Challenges. Resources. we are as thorough as our resources, and so we must work on improving them. And same with workforce and facilities. So this is a worldwide issue for rehab, but I think we are also globally very good at advocating for those, but that will tie hand in hand with commissioning. We have to have money to recruit more people, to get more facilities, and to have more resources. So commissioning usually we have very tight rules around commissioning in England for the rehab units and for community provision. However, we are fortunate to be granted with full MDTs and units, although we have limited beds, and we have inpatient and community resources available, but they all come with challenges. And again, specialist trained clinicians and specialist units are imperative to deliver tailored goal-based rehabilitation and a holistic approach in stroke rehab. Because I'm rehab, I usually consider the rehab physicians as the artists of medicine. So we have to increase the workforce and the units. That's my view. Summary. So I'm going to try to summarize. We very briefly touch base on the stroke facts and highlighted to identify a cause if possible, because we need to modify factors when we can, especially with secondary prevention. Remember, blood pressure management and statins and goal-oriented rehab is our key. We must know what we're aiming for to work for it. And neuroplasticity wise, we are trying to train in the early phases rather than compensate, but we do use some compensation methods because life goes on. Medical issues, remember hemorrhagic transformation and acutely unwell patient after stroke, and you may need an urgent CT. Your patient would need immediate attention. Remember bronchostorm stages of motor recovery. And remember the spasticity patterns, and remember it's not always bad, but if needed, you can treat. You can use toxin or splinting or physical measures if needed. Pain, we touch base on the hemiplegic shoulder pain as a specific issue for stroke rehab. That needs an MDT approach, and prevention is key, but we can utilize taping, intraarticular steroids, medication, or nerve blocks if needed. Swallow and speech needs an assessment within the 72 hours after stroke onset. And swallow, we usually utilize diet modification, but patient may choose to do risk feeding. And speech, we usually consider communication aids on the later phases of stroke rehab and focus on therapy. However, we use basic communication aids so patients can communicate their needs. And bladder, we talked about that. We'll usually find our patient with an indwelling catheter on a rehab ward. We may consider trialing without them, but we don't rush into that, and we assess our patients globally. Again, bowels can be a limiting factor in daily life and have direct impact on quality of life. And we'll look into if that's diarrhea or constipation causing overflow. We touched base on the stroke rehab in the UK, and I think we all agree to improve training and resources across the globe. That's all of my talk today, and I would love to hear questions if anyone has any. Thank you very much.
Thank you very much, Ish, for that wonderful coverage on acute rehab on stroke. Any questions from the physical audience here? One of the areas which I would like to again ask you about the interesting part of whether to train or compensate, especially the after a stroke. The recovery of upper limbs or hand function seems to be a problem at the moment. Most of the time we can get them walk. I'm sure that may be a scene worldwide. So when do you really decide when to start compensation or give up training, or should go both together from the beginning? What's your thoughts on that?
I'm sorry, but can you question? There's a real echo from the microphone, I think.
Can you hear me well now? Is it still echoing?
It's a bit better. There's still some echo, but if you try again.
Yeah. Is it clearer now, or how are you?
That's a lot better. Yes, that's a lot better.
Okay, right. Good. Thank you. Yes, the question is about when to think about start compensating, especially the upper hand function after the stroke, which generally takes a long time sometimes and may not recover hand function. So, do you start compensation and training together, or when will you decide that you will start on compensation and give up training? Is there any things that we can learn from your experience?
Yes, that's very good. That's very point, and it's really very delicate decision making. But the evidence shows neuroplasticity wise, we must focus on rehab, on training, and especially with repetitive tasks. And if you could do concentrate induced movement therapy or mirror therapy, that would even enhance neuroplasticity. Compensation should come later. Because then the functional MRIs show that it's difficult to train when you start compensation. In the early phases, it's probably better to focus on that, let's say in the first 4-6 weeks. But after 3 months, we know that hand function is a prognostication factor. So if we don't have any return of hand function after 3 months, then it's probably not going to happen. And that's what the evidence shows. Then we'll start more focusing on compensating. Would that answer your question?
Yes, that definitely is. Yeah, thank you. Any more questions, Gurendrika?
Do you recommend sprints during the early stage of stroke rehabilitation?
That's again a good one, because shoulder splints, physios would say no, doctors would say yes, usually. But it's controversial. We don't have to be we shouldn't be limiting, and we should allow a lot of mobilization. So taping has been increasingly popular, especially in hemiplegic shoulder pain management. Spasticity, we don't recommend anti-spasticity splints in the early phases. Well, we can utilize simple splinting to maintain a natural posture. Rather than splinting, we would recommend more supportive measures, like very simple, just supporting the shoulder, for example, for shoulder pain, or for hand, again, a very simple off-the-shelf splint rather than a custom-made one, not in the early phases.
Thank you. And one small question. It's about not about early stages. When you introduce walking aids, what is it a disadvantage?
No. So walking aids would not be a disadvantage in my opinion. Obviously, we do a phased gait training. We have to be able to sit, maintain sitting balance, stand, maintain standing balance, and perhaps step in parallel bar first, and then outside of the parallel bar. Walking aids often promotes early mobilization, but it's something dynamic. We don't establish walking aids early, so patients can start with, for example, a Zimmer frame, then they can progress into a quad stick, then a regular stick, then they may not need it in the late phase, etc. So I think we need to review and reassess as needed, but it would not be a setback for a patient.
Yes, thank you.
Thank you, Dr. Ish. In time of interest of time, I think we should let you go to your work. So thank you very much for joining us this early morning to enlighten us on this very common topic with common problem to all of us. And so hope to that you will join us again whenever we have sessions like this, and with Sri Lanka College of Physicians as well as Sri Lanka College of Rheumatology and Rehabilitation. Thank you very much, Ish, for joining us.
Thank you very much for inviting me. I had the pleasure of working with one of your trainees, Cham, for the last year. It's been a great experience. So thank you for inviting me. So I feel the warmth of sunny Sri Lanka from the screen, because it's really raining in England and it's quite cold. So have a nice day. I'll go to hospital now. Thank you very much.
Thank you. Right.
Thank you.
Move on to the last lecture for today. Yes, Gurendra, please.
So now it is Dr. Kalhari Sewandi. She is a graduate from Faculty of Medicine, Colombo, and she completed her MD Medicine in 2020. She recently completed her post-MD training in rehabilitation medicine. Her overseas training was in East Sussex, UK. Kalhari's talk for today is going to be on useful insights into common impairments beyond routine physical examination.
Thank you for that kind introduction, madam, and good afternoon, and welcome to the final talk of the day. And before going into the talk, can I ask you a question? How many of you are having stroke patients in your wards right now? Patients with strokes? Okay. Right. Are any of those stroke patients having left hemiplegia, right hemispheric strokes? Yeah? Good. So I made two assumptions when I'm wording this topic, that the impairments that I'm going to talk to you today are common, and the insights into those impairments are useful in your clinical practice. And I hope that it would hold true, because some of you have stroke patients in your wards right now. And the term impairments comes from the International Classification of Functioning, as my colleagues introduced the concept. And if we take stroke as a health condition, the impairments at the body structure, body function would be, for an example, hemiparesis, hemianesthesia, hemianopia, hemineglect, and cognitive deficits, and also language deficits, and impairments in the pain sensation, and impairments of muscle tone, for an example. So impairments, there are many according to the classification, and the problem with the routine medical history and examination is that we focus on the diagnosis mainly and the associated complications, etc. And in that process, we miss the impairments which have a functional significance to the patient. So the talk would discuss 3 common impairments, particularly common in right hemispheric strokes, I would say. 2 of them are common in right hemispheric strokes. And I would brief you with those impairments and how to detect those: spatial neglect, anosognosia, and trunk instability. Before going into the first impairment, spatial inattention or spatial neglect, about attention, we concentrate a lot on attention, particularly on brain injury patients, because it's very common after brain injury to have attentional deficits. Sustained attention is a prerequisite for learning. And without the patient's attention on what you say, the patient will not be participating in your therapy program. So attention is determining motor recovery, in other words. Basic form of attention would be arousal, that is the ability and the readiness to respond. I'm sure all of you are alert right now. So we talk about alertness when we talk about consciousness. Selective attention is where you focus on something by, on the other hand, while ignoring the other stimuli. And sustained attention is where you where you maintain attention for a prolonged period. For example, you have been now concentrating on this lecture series for more than an hour, so that is sustained attention. So divided attention is when you do multitasking, you pay attention to both tasks at the same time. So what I'm talking about today, talking to you about today, would be spatial attention, where one has the ability to pay attention to all parts of all areas of the space around you. So spatial neglect is a problem with spatial attention, and it's not a visual problem. So it's basically a cognitive impairment, and it's common after right hemispheric stroke. And spatial neglect can be multimodal. Often it is multimodal, although we assess only the visual component of it. So you can have inattention to the visual stimuli, auditory stimuli, and tactile stimuli, and olfactory stimuli in a particular hemispace, either left or right. And mostly it's the left hemispace, because attention is, as a brain function, is lateralized to the right hemisphere. So it's the right hemispheric strokes, mostly right MCA territory strokes, that we see spatial neglect. And it's commonly missed in routine acute stroke care. And this spatial neglect causes poor functional outcomes, particularly even the poor outcomes with regard to the gait training and also in the upper limb training. So this patient has left hemiparesis and left neglect, and the patient is resting, meaning that there is no person talking to him in the right hemispace, but still his head is turned into the right side and his gaze is turned into the right side. So you can appreciate it on the initial CT that he has had, that the cut shows that the head is turned into right, and the eyeballs are also turned into right. And if you give a task for this patient, if you give this picture to describe, the scan path, visual scan path of the patient is indicated in red, where the patient concentrates only on the right side of the page, and he misses this boy on the left side of the page completely. So this is neglect into left hemispace. So neglect and hemianopia. In a large MCA territory stroke, there is a chance that you might also have hemianopia in addition to hemi-neglect. So when both coexist, which is less common, I would say, is difficult to clinically differentiate. So this is just to appreciate that left hemianopia is a visual problem where left side of the visual field is missing, and left neglect is a situation where you don't pay enough attention to the left hemispace. And unlike left hemianopia, which follows midline, left hemi-neglect, or neglect in hemi-neglect anyway, will not strictly follow midlines. It's not. So, and the other difference would be if both coexist, the functional outcome would be poorer, because for obvious reasons, left hemianopia is not recoverable. It doesn't have a spontaneous recovery. But in left hemi-neglect, there is a spontaneous neurobiological recovery, which is associated with neuroplasticity, and rehab interventions can make a change. And extinction to bilateral simultaneous stimulation is something that we can do at the bedside to screen for neglect. But it's just a single feature of the neglect syndrome, which has multiple clinical components. So as you are all aware about the testing of extinction, this patient responds to wiggling of fingers on the left hemispace and also in the right hemispace when those are done separately. But when both stimuli on two different sides are given simultaneously, patient pays attention only to the right side, and the left-sided stimulus is extinguished. So that's visual extinction. We can test the same thing for tactile sensations by stroking the hands of the patient, if the patient is not totally hemi-anesthetic on one side. So this, as I said, extinction to bilateral simultaneous stimuli can occur in multiple modalities: visual, tactile, auditory. So if a patient demonstrates extinction in two modalities, that strongly suggests that the patient is having neglect. And the other thing that we have to keep in mind is it's just a screening test, and you might not demonstrate extinction in all the times that you examine. So you might have to repeat it. But the other tests to screen for neglect are mostly paper and pencil-based tests. There are cancellation tests. Line cancellation test is one of those. This is just an A4 sheet with 40-odd lines. And the task is, and this is presented in the midline of the patient, and the task is to cross all the lines. And you can see that this patient with left hemi-neglect has crossed out only the lines in the right extreme of the paper. And that tells you that this is not a strongly midline sort of associated phenomenon. Star cancellation test. Again, another A4 sheet with this picture, and the task is to cross out all small stars. So there are visual distractors: large stars, short words, and letters. And you can see the patient with hemi-neglect has not crossed, but circled only the small stars in the right extreme of the paper. Letter cancellation test. The task is to cross out all letters, all letter H. Another test would be line bisections test. Again, another A4 sheet with lines of different lengths drawn. We can quickly do it. And the task is to asking the patient to bisect the lines, that is, to mark a midline of each line. So the response of a patient with hemi-neglect, left hemi-neglect, would be like this. All the bisects, the marks would be shifted towards right. So this is supposed to be less sensitive than cancellation tests, but if the line is longer enough, they say more than 1 centimeter rightward shift would be indicative of neglect. So these are all features of neglect syndrome. Behavioral inattention test is not free. It belongs to Pearson, but it's a conventional battery of tests to assess neglect, but the conventional version includes 6 tasks, and 4 of those are the previously described tests: line cancellation, star cancellation, letter cancellation, and line bisection. And the other 3 would be copying these figures: 4-point stars, cube, and a daisy. And you can see that in a heavy neglect patient, the important elements of left side of these figures are missing. And drawing a clock face is another one to screen. And you can see the bunching of letters on the right side. Usually they draw the full clock. So this shows some of the other observations that we can see in these patients. I'm not sure whether you could appreciate a well-shaven right side of the face, and the left is untouched. And this is termed as hanging eyeglasses sign. If you could notice, the left temple of the spectacles are not sitting on the left ear, and it's sitting on the head. That's because when the patient wears the glass, the leftward movement in the left hemispace, even the movements are of smaller amplitude. So that tells you that there's a motor component to the neglect as well. So the movements, the amplitude is less. So habitually, he has been wearing the spectacles like this. And this picture shows the patient doing a line cancellation test, and you can see the trunk. It's rotated to the right. and the head and the gaze is rotated to the right. And one can say that he might be even pushing his body into the left side, which I will talk to you in a minute. So this demonstrates a series of self-portraits by a late German artist who has suffered a right hemispheric stroke. And you can see with time the improvement of the appreciation of his left side of the face. So this tells that neglect is improving. It's amenable to be improved, and it follows neuroplasticity. And rehab outcomes are beneficial because not all neglect patients will have complete spontaneous recovery, and about 10% will have chronic neglect, which will cause functional problems. The second impairment would be anosognosia, which is usually associated with neglect, and it is described in the literature with a left heavy spatial neglect. It implies that the person lacks awareness of his own impairments. So this is discussed in psychiatry as well, when the patient doesn't have insight into own mental health condition like schizophrenia. But here, it's in the neurology, where a patient lacks insight into his left hemiplegia, left neglect, and all the impairments associated with a right hemispheric stroke. We commonly see it anosognosia. And we sometimes even tend to treat these patients under their best interest, and mostly they are under DOLS, we call it. The degree of unawareness of the deficit can vary among patients. Some people will say that they are being told that they have impairments, but they don't believe that they have impairments, and they sometimes ask for self-discharge. So to assess spatial neglect and anosognosia, another less complicated way would be for the occupational therapist to complete this Catherine Bergerco scale in function. So as an example, the patient would be inspected to see if he forgets to groom or shave the left side of the face. Again, secondly, whether he experiences difficulty in adjusting the left sleeve or the slipper, that is grooming, whether there's any inattention. So in different tasks, daily activities, the patient would be observed to see how much of neglect is present, and it would be scored according to no neglect, mild, and severe. So the same questionnaire, these 10 items, can be given to the patient, and the patient can rate his or her own impairments. So the difference between the score would give you an idea about the severity of the anosognosia, the lack of impairment, the lack of insight into the impairment. Third impairment I selected was trunk control, because we all can appreciate impairment in trunk control in high paraplegic patients, thoracic level, or tetraplegic patients. We know that the trunk control is impaired, but hemiparetic patients, sometimes it's underestimated. And in acute stroke, trunk control is impaired. And you can see these patients with, all three patients are having right hemispheric strokes with left-sided hemiparesis. And the first one is upright with good trunk control. And second one has a tilt towards the left side, paretic side, and he's supported. And the third one is even tilted to the paretic side, even in the sitting position. So there's a variation of the trunk control. So trunk control may predict post-stroke gait recovery. So I think this is useful just to have that idea as you all are managing acute stroke patients. Twist algorithm, time to walking independently after stroke. It's a simple tool that can be applied 1 week post-stroke. And it's not rocket science, it's obvious. It uses two clinical measures. One, trunk control, measured by the trunk control test, which I'm going to talk to you in the next slide. And the hip extensor muscle power. To tell you about the trunk control test, it basically assesses 4 items. Whether the person can roll to the weak side. If he can do that independently in the normal way, scores 25. Rolling to the strong side, if he can do independently in the normal way, 25. But if he can do independently, but in an abnormal way, he scores 12. And the other items would be balance in sitting position and sitting up from lying down. So we have a total of 100. So going back to this twist algorithm, if the trunk control test is more than 40, that means basically if the patient scores for independent turning normally in the bed, so that basically tells you that the patient will most likely walk 6 weeks post-stroke. If the trunk control test scores less than 40, then the next step would be the hip extension. If the hip extension demonstrates anti-gravity power, 3 or more power, so he's likely to walk within 12 weeks, in 12 weeks. But if the hip extension power is less than 3, it's likely to be dependent at 12 weeks. That doesn't mean that the patient will never going to walk, but it's just the prediction of how quickly they would walk. And if this is used for the right reason, this is all right, not to limit patients from rehabilitation, telling that you wouldn't walk or that sort of a thing. So those who tilt toward the paratic side are not all the same. Some will just tilt towards the paratic side, and they would not fall because they feel that they are going to fall, and they would prevent, if left side, they are tilted, and they feel that they are going to fall, and they, from the right side, they would try to grab something and prevent the fall. So that's just the listing phenomenon, listing to the left. But there's another set of people who really push to the paratic side, so that's pusher syndrome, or in other words, lateropulsion is a better term, where they actively push the body towards the paratic side across the midline, and they would fall if they're not assisted. So the mechanism of this pushing is proposed in studies like this, where the patient is seated in an apparatus, which is a wheel, and eyes are covered. And if this is the starting position, A, patient is moved to the opposite position and asked to report when he feels upright. And by the way, this is a patient with right hemispheric stroke, with left hemiparesis. So patient reports that at the position B, he feels upright. Now you can see that the patient's subjective postural vertical, we call it, not the visual vertical, because like the patient is closing the eyes. But posturally, he feels he's in the midline only when he's turned a little bit to the left. And the same individual, when the starting position is C, he reports that he feels upright in this position D. So this gives the subjective postural vertical of the patient, which is tilted a little towards left. So from this research, they proposed the mechanism of pusher syndrome as an altered verticality perception in the brain. And they also goes on to hypothesize that the graviception or verticality perception is situated, as a function of the brain, is lateralized to the right hemisphere. Anyway, the wrong reference of the verticality, that is the postural vertical, with that wrong reference, the patient actively pushes to align the body position with the new perceived vertical. So that's the mechanism that they postulate. Having said that, the point is that if a stroke patient is having impaired trunk control, that person would benefit from specialized rehabilitation. Scale for controversy pushing is the tool that we can use to quantify and grade this impairment. And it basically grades lateral body tilt, pushing behavior, and the resistance to correction of the vertical in sitting and standing position. So that brings to the end of the talk. The key messages would be, in patients with hemi-neglect and anosognosia, these impairments delay functional recovery, and screening for them early in the acute stroke period, even if the hemiparesis is mild, because you might have a left mild hemiparesis with spatial neglect and anosognosia. So the upper limb recovery of that left upper limb would be slower, and maybe he would end up as non-functional upper limb. So referring is important. And with regard to trunk control, it can be used to gauge how fast the patient would walk in the acute phase. And observing bed mobility in medical wards can be beneficial, just to picture who would need inpatient rehab referral at the end of a few weeks. And latropulsion or pusher behavior may delay post-stroke functional recovery, and referring them to specialized rehabilitation is also beneficial. And thank you for your sustained attention for 1.5 hours.
Thank you, Kalhari. I think that brings a new insight into some of the common problems actually we see. A question from me. How do you intervene at these stages? Are there any specific things they do to improve? Because ultimately this will affect their function. So.
Yes. So if I talk about neglect, there are special interventions like using prism adaptation. But even in the UK center which I used to work, they don't use prisms. So evidence is there for those type of interventions. But knowing about the impairment and having an understanding why the patient is not using the upper limb functionally is important for the therapy team to come up with interventions which are more practical, I would say. So that's my answer to that. With regard to latropulsion or pushing behavior rehabilitation, it's about balance training, and it's about repetitive task practice and giving tasks to improve the balance. Other than that, there are no sophisticated sort of interventions in any of the 3 impairments that I spoke about, other than the prism adaptation, which has a good evidence base for neglect.
So that is more, occupational therapists will have a major role in this as well. Enrica, anything? Anybody from the audience? Any questions?
If you have any later thoughts, you can email. If I know, and if I can do a literature review and then give you answers.
Yeah, thank you very much, Dr. Kalhari, for that wonderful lecture. And also, I think we didn't take any question from Chamara. Any questions from Chamara? Chamara, you talk about this donning and on and off of sprints at the acute stage. You said it's 2 hourly. So that means on for 2 hours and off for 2 hours. Okay, that's what you had. Yeah. Okay.
Yeah, it's so the patient should wear it for 2 hours and then off for 2 hours and then again for 2 hours.
How do you do it in the night? Do they use it all night or not?
I mean, it depends on the stage. If the spasticity is very severe and kind of impairing, then yes, it can be left. But again, always we have to check the, before applying, we always have a look at the sites at risk. Yeah.
Pressure can be a problem. Yeah. Okay, so that will conclude our session for today. I think that would be a very useful one. This will go online shortly in our YouTube, College of Physicians YouTube. So that will be disseminated. Probably we should be disseminated among our team members, both physiotherapy and occupational therapy and the speech therapists as well. I think that will be very useful for them all over the country. So again, my gratitude to all 3 speakers, so as well as my co-chair on behalf of the Ceylon College of Physicians. And to hand over the certificates, I would like to ask Chamara and Kalhari to be on stage again. And can I have Dr. Panangal also on stage to hand over?